Good morning, dear friends. I am Dr. Visalsa once again in front of you with the very interesting topic for today, that is diabetic ketoacidosis. As a part of Project Krishna, there are various activities which are ongoing in Swasthya Diabetes Care. One is the Make My Life project. The main motto of Make My Life project is for type 1 diabetic patients, we want to create a center of excellence for all the friends. Instead of hiding the disease, they should feel confident of the disease. Yes, very true and very moral support which is provided by the Swasthya Diabetes Care by giving this sentence. In each and every diabetic patient, specifically a type 1 diabetic patients, they are suffering from either hypoglycemia or a diabetic ketoacidosis when their diabetes are under control or over control. So our aim is that they should feel confidence. They feel uh, confident about their disease. They don't have any sigh by representing themselves in front of societies. So for that, the knowledge is must. And we are with the diabetic ketoacidosis, one of the life-threatening complication which occurs in a type 1 diabetic patient. So it is acute metabolic acidosis, mainly occurs in type 1 diabetes. Sometimes it occasionally occurs in type 2 diabetes, specifically when they have some other illness, long duration of diabetes, or they have complete depletion of insulin stores. Now, what is DKA? DKA is basically a metabolic decompensation. Mainly occurs because of the severe deficiency of insulin action combined with the increased level of counter-regulatory hormones, specifically primary glucagon, catecholamines, and growth hormones. The tried to identify the diabetic ketoacidosis, that is hyperglycemia, high blood sugar level, ketosis, the presence of ketone bodies in the blood, and the acidosis, where you have a blood pH less than 7.2, say less than 7. So these are main triad to identify whether the patient is suffering from diabetic ketoacidosis or not by doing a symptomatic, by doing some laboratory investigations. So plasma glucose values in DKA patients usually on a higher side, but maybe sometimes is misleading low on occasions. Based on laboratory values, diabetic ketoacidosis can be classified in mild, moderate, and severe patients. We take two parameters, that is pH, blood pH, and the bicarbonate level. Mild, moderate, and severe differentiate by the pH values, that the pH value is less than 7, the decay condition of particular patient is very severe. Moderate 7 to 7.24 and mild decay intimate that the pH value 7.25 to 7.30. Simultaneously, you need to also look for the bicarbonate values less than 10, bicarbonate value that is less than 10 milliequal per liter, that is a severe diabetic ketoacidosis. Moderate when the bicarbonate value is 10 to 15, and mild when the bicarbonate value is 15 to 18 milliequal per liter. As a doctor or treating physicians or your Saarthi as a project in a project Krishna, the treating part of a diabetic ketoacidosis may not be available at home. You are on a telephonic talk with some of your patients or patients' relatives or the parents, and the parents are saying that my child is suffering with some complications. He is already on an insulin, type 1 diabetic patient. I am assuming that his blood sugar is very high and it might be leading to a ketone body production. So this is a layman terminology which the patient tells to you. Now, our duty is to identify the factors which actually precipitates this type of condition. So the precipitating factor includes mainly the precipitated by the willful or inadvertent cessation of insulin injections. The type 1 diabetic patient sometimes told you that, yes, I am taking regular insulin injections, but it might be possible that they are not taking insulin or they are decreasing a dose of insulin, which actually they require. Some other times, it is when the increased demand of insulin is required, but that will be not fulfilled by the increase in dose of insulin injections. Other precipitating factors are some trauma, dehydration, or some other infarctions, the cardiac myocardial infarctions like this. Nowadays, in a type 1 diabetic patients, the continuous insulin infusion, that is by insulin pump, is very becoming a common terminology, that the child is using insulin pump for taking regular insulin injections. But let's say it is a closed loop technology. Sometimes the pump failure cannot be identified very easily or at a time, and that leads to the presentation of a DKA, that is diabetic ketoacidosis, because of the less insulin is going to inject in type 1 diabetic body, type 1 diabetic patients by insulin pump. That is we call it the pump failure. So these are some of the commonest precipitating factors which leads to the presentation of diabetic ketoacidosis. Now, why this occur? That is our understanding. When we understand a disease properly, we can treat it properly. So the pathophysiology behind the diabetic ketoacidosis includes first and primary is because of you know that type 1 diabetic patients are insulin deficit patients. That's why they require frequent insulin injections. So metabolic changes are due to absolute or partial deficiency of insulin with increased level of counter-regulatory hormones, includes the glucagon and other counter-regulatory hormones, which leads to increased concentration of glucose in a body. Let's say which are the organs are going to be involved in this type of complications. They are the liver, muscle, adipose tissue. What are the role of particular liver is that when the person is insulin deficit, the liver starts to produce more glucose, that is gluconeogenesis and glycogenolysis. Muscle starts to doing a proteolysis, that is protein breakdown, and adipose tissue is going to do a lipolysis. This all in together generates more amount of free fatty acids that is delivered to liver, and that will ultimately lead to production of ketone bodies, that is we call it ketogenesis. That ketogenesis production, that is a beta hydroxybutyric acid, serum acetone. These are the ketone bodies which present in a blood that we call as a ketonemia. And this ketone bodies also leads to decrease in your blood pH and leading to a metabolic acidosis. When you have involvement of muscle, adipose tissue, and liver, when there is decreased glucose utilization because of insulin deficit and increased glucose production by the liver, you have a hyperglycemia, excessive water and electrolyte losses. You have also some osmotic disturbance, that is we call it the osmotic diuresis and dehydration along with this. So this all lead to the loss of glucose, presence of ketones, and water along with the sodium, potassium, magnesium, and phosphorus. There is also increase in lipolysis with the decreased fat synthesis, which leads to increased fatty acid and glycerol level. So this is a basic pathophysiology of a diabetic ketoacidosis. When you understand this, how you're going to treat it, that is also a question. For treatment portion, we understood the symptomatic part also first, that in a diabetic ketoacidosis patient, what are the symptoms or signs which you can look for? As I told earlier, this complication cannot be treated at home. If the person is suffering from moderate to severe diabetic ketoacidosis, it requires a hospitalization. But before that, you need to identify whether the person is actually suffering from DKA or there are some other causes or there are some other factors. So what are the symptoms and signs for diabetic ketoacidosis patients? One is symptoms related with the hyperglycemia. That is the symptomatic presentation because of an increased blood glucose level. That includes the polyuria, nocturia, thirst, weight loss, malaise, lethargy, some visual disturbances. The child may have abdominal pain, anorexia, vomiting, nausea, or a breathlessness. And along with that, you have a symptomatic presentation because of a water loss, osmotic diuresis, presence of ketones, and metabolic acidosis. That includes the dehydration, loss of skin turgor, hypotension, the child is tachycardia, hypothermia may be seen. Yes, you can look for the acetone breath order. When you have a ketone body present in a blood, the serum acetone breath, that is a foul smell or the ripe fruit smell, which is seen, which is you can actually smell in the breath of a particular patient suffering from type 1 diabetes. You can also check the respiration. It is somewhat Kussmaul's type rapid respiration. Hyperventilation, hyperreflexia, and child may enter into the coma if the treatment has not been started on an urgent basis. So these are some symptoms and signs which leads to the presentation of a diabetic ketoacidosis. What are the investigations you can ask for? Yes, first and foremost, as a Saarthi, when you have any such type of case, which you think that the child is suffering from DKA, you ask them to immediately contact a nearest hospital center. You doesn't allow the child to remain at a home and treat himself or herself by own or their parents, because the treatment portion of a diabetic ketoacidosis, when you need to give a particular specific treatment and some fluid replacement, cannot be done at home. So primary aim is to hospitalize particular patient. Then you go for the symptoms and sign investigations. That includes glucose level check, ketone body check. You can check electrolyte, sodium, potassium chloride, magnesium. You can also check a creatinine level. So initial investigations will only show hyperglycemia with the elevated level of beta hydroxybutyric acid, that is a ketone body. Then you also check for the arterial blood gas analysis that usually shows the high anion metabolic acidosis. In a diabetic ketoacidosis patients, you also measure the electrolyte levels, specifically a serum potassium level. So when you measure a serum potassium level of a particular DKA patient comes to you, it is very high to very low. It may fluctuate. But there will be huge total body potassium deficit in most of the cases. So following a correction of hyperglycemia and fluid deficits, once you start a treatment, the true picture or the true level of serum potassium will emerge. So that's time you need to check serum potassium level every 4 hours or whatever it requires. And similarly, irrespective of the serum sodium level, there is invariably a major total body sodium deficit can be seen. So sometimes along with the treatment of diabetic ketoacidosis, you also need to do a potassium replacement therapy in a diabetic patients. So treatment option for a DKA patient, although as a part of our treatment option, this is we must know, because the questions can be asked from your particular type 1 diabetic patient as a Saarthi, that if I am suffering from DKA, what should be the treatment option? That is for their understanding only. Remember, the treatment is only in the hospital setting. So the fluid and electrolyte is must to replace. As it takes about 48 to 72 hours for DKA to develop. The full replacement of the previous losses and correction of acid-base disturbance should be done with the same speed. So it is not in a haphazard manner. 1 liter of normal saline should be infused in the first 1 hour, then next 1 liter in the next 2 hours, 2 liters in next 4 hours, 2 liters in next 8 hours. About 4 to 6 liters of fluid should be given within 24 hours. Remember that whenever you give a fluid replacement therapy to a particular DKA patient, the age, particular weight, and the type 1 diabetic duration, the level of ketones are also matters. If the serum sodium level are more than 150 milliequal per liter, you can use a half normal saline instead of a normal saline. When the blood sugar level reaches around 250 milligram per deciliter, the fluid should be changed with the 5% dextrose saline drip, along with the administration of insulin to prevent hypoglycemia. Remember, when you give a fluid and electrolyte therapy to a type 1 diabetic patients, you must avoid overhydration. Potassium levels should be monitored regularly. Alkali therapy may be considered if the pH is less than 7.2. If it is less than 7, alkali therapy is essential. So you also look for the bicarbonate value and the pH value by doing arterial blood gas analysis, and according to that, you need to treat the particular patient. The profound unexplained weakness suggests hypomagnesemia. If required, 2 ml of 50% solution can be given intramuscularly for the initial correction. Early instruction of oral feeds take care of the deficiency. Milk especially helps in cases of phosphate deficiency. This is a one part of your treatment for a type 1 diabetic patient. Simultaneously, the insulin injections or the insulin is also going to be supplemented. Routinely, the type of insulin used in it is a regular human insulin or a rapid acting analogs. The preferred route for injection is intravenous. In a DKA patient, you need to give intravenous insulin injections in a slow drip. But if it is not possible due to any reason, intramuscular is alternative route for which the deltoid muscle is preferred. So how you are going to give intravenous insulin injection? First and foremost, when the child comes to you, you measure the blood sugar level, start initial 10 to 15 minutes of insulin is given as intravenous bolus dose, followed by the infusion at the rate of 0.1 unit per kg per hour, which can be adjusted according to the patient's original dose of insulin and blood sugar level. So what you have done, you have started fluid replacement therapy. You have also started intravenous insulin injection therapy, bolus followed by the slow insulin drip. You also monitor the potassium level, you monitor the pH values, and you monitor the magnesium values. So these are 5 basic roles: fluid electrolytes, insulin intravenous injection, slow followed by the bolus, followed by the slow insulin drip. Measure your serum potassium value, electrolyte values. Measure your pH, metabolic acidosis, or the arterial blood analysis, pH and bicarbonate values, and magnesium values. And routinely, every 2 hours, 1 hour, 3 hours, 4 hourly, you measure the blood sugar value. And according to that, you adjust the insulin drip. Also remember that the rapid correction of blood glucose should be avoided, as it may lead to a cerebral edema. Once the blood glucose level comes down to around 250 milligram per deciliter, the fluid replacement should be switched over to the dextrose saline infusion instead of normal saline. As the patient's sensory level improves and he starts taking oral feeds, insulin can be given by subcutaneous route. Sufficient overlap should be provided between the initiation of subcutaneous insulin and the termination of IV insulin to allow enough time for the former to take effect. So this is a part of a treatment in nutshell, as we require a good hospital setup, if require ICU setup for a DKA patient to be managed properly. Supportive care, appropriate antibiotic, you need to look for the precipitating factors, trauma, infection, etc. Provide sufficient antibiotic coverage. Also, you need to give, if required, epinesins. In a drowsy patient, the catheter should be there. And in the patient in a comatose stage or not having proper consciousness or semi-conscious stage, comatose stage, nasogastric tube is required in case of patients with acute gastric dilatation. So these are some of the supportive care which need to be taken care when you treat a type 1 diabetic patients. Let's say the treatment also have their own complications. What are they? When you give a treatment to a type 1 diabetic patient suffering from a diabetic ketoacidosis, these complications should be checked for. The hypoglycemia. You give an insulin infusion, intravenous bolus, measure the blood sugar level regularly, and don't let the patient go into a hypoglycemia, that is a very low blood sugar level, or a hypokalemia also. Cerebral edema, acute respiratory distress syndrome, relapse of DKA, non-metabolic complications like infection of skin, lungs, urinary tract, etc. Arterial thrombosis, aspiration, pulmonary edema. These are some of the complications which can occur in a DKA patient during the treatment or after the treatment. Diabetic ketoacidosis is one of the acute complications of a type 1 diabetic patients. So our aim as a part of Project Krishna, we need to control our type 1 diabetic patients' blood sugar level in such a way that he might neither go into hypoglycemia nor he or she is going to be suffer with the diabetic ketoacidosis. So the regular follow-up with your type 1 diabetic friend as a part of Project Krishna, regular checking of blood sugar level, regular monitoring of their insulin dosage, and the decrease or increase of insulin dosage. If the child is taking or using insulin pump, you can measure the serum or blood glucose level with the help of CGMS like this. So this all parameters helps to control their diabetes in such a way that they have a routine normal life without any complication. So thank you, my dear friend. I hereby end my presentation. And yes, after this presentation, as our Project Krishna part, we are going to give you a few MCQs, that is a multiple choice questions, which you need to answer in the form, and that will help you to gain the certification for this Project Krishna work. So, thank you very much, friend. Have a nice day.